Greetings and welcome to Basic Nursing for Psychiatric Technicians. I'm going to go ahead and review Chapter 1. We did go over some of this in class, but I'm going to go ahead and go through it again. What we look at and the reason for a basic nursing class for psychiatric technicians is because oftentimes, and especially with the parity law, for those who don't know, the parity law is a law that was signed back in 2009 that gave substance abuse and mental health diagnosis the same value, the same worth as any other type of medical diagnosis. So it's important for us to realize and know the medical terminology and the nursing practices, because if we work in a detox facility or a larger hospital facility, even if we work as a CI or go on to be an LCDC, it's important to know the practices of the nurses and the psychiatric technician. Many of you have done or will do a 275-hour in practicum in order to fulfill that part of your skill set. So what determines mental illness? Well, there's a difference between a mental health and mental illness, and it can be cultural, family, or individual beliefs. Basically, each person or each group has their own way of looking at things. Now, the goal is on the continuum is to be towards mental health. And then some people will be on the continuum side of mental illness. What we should be working on as counselors in the field is we should be working as, and that's why our program is called Student Association for Mental Health Services, because substance abuse is mental health. Substance abuse counseling is mental health. So, even on the sign on our door for our classroom says mental health, because the thing is that you're going to see more and more of an integration of multidisciplinary teams, more higher level licensures who are going to backtrack and do their LCDC in order to be well-rounded. There are some factors between that precipitate the illness, mental illness, and they're listed here, and this is also in your book. And then there's factors that help to bring these things to the light, which is what we call the mental health movement. The description of mental illness is a sense of disharmony with aspects of life that are distressing. Any person who has mild, moderate, or severe depression, bipolar, anything that is causing their life to be out of order, alcoholism, drug abuse, or even, this is real popular in popular culture, hoarding, other type of things. The distress can be associated with the mental illness. It can be experienced just by the individual. The individual's response or symptoms can be felt by the family, friends, and the community. And I told a story in class about having family members. I have a family member who has severe schizophrenia, and it really his symptoms and his episodes don't just affect him or the family. They really affect the whole community. What we want to do in mental health is we want a sense of harmony and balance in individual, family, friends, and we want community, and we want continuity in services. Too many times there's red tape. What I hear from a lot of students coming into the field is why is there so much red tape, and as far as the lack of services or being able to identify when there's a need for social or service change. And so those of you who are going on to be social workers, that'll be an important part and a role that you can play. Some aspects of mental health are social, emotional intelligence, and that's a person's ability to have good social norms, social boundaries. Someone who has resilience, who's able to, serenity prayer works for this. People who are able to look at themselves as who they are with symptoms rather than identifying or being labeled with a diagnosis. And then spirituality, which is something that helps us. That's why the serenity prayer I brought up, something that helps us to see ourselves as a part of something greater than ourselves. Now, some concerns is that mental, behavioral, and social health problems are increasing. We have a larger population, so that's kind of a natural thing. But also, as many of you have mentioned out, that you're going to, or that you plan to work in geriatrics. Now, keeping your substance abuse license and going into social work is an excellent option because there are higher and higher numbers of retired people who are becoming addicted to opiates, pain medication, or other things. So that's definitely a good area. But they're increasing for many reasons. Lack of family roles in the adolescent population. And I think that single mothers and single fathers do a great job. But there are some cases where the children fall through the cracks and may begin to experiment with drugs or gangs or anything else. Mental illness has been classified as a public health crisis in the United States, and President Obama has mentioned mental health in his most recent State of the Union addresses. He has talked about that, especially in regards to the mental state of the past three shooters at the theater, at the school, and then again in downtown New York recently. So it's an important task for us to assess and evaluate, the substance abuse and co-occurring diagnosis. Now, there are many theories behind why someone has a disorder, and most of it is seen as a brain chemistry disease. But there are several neurobiological theory principles. One is brain dysfunction and behavior, that some type of brain dysfunction or disorder and development of the brain leads to the behavior. And then the other one is genetic influences on behavior, and you can look at hereditary and see how those chemical imbalances or brain deficiencies are passed out from generation to generation, which is how we describe that as the generational, genetic, or even whenever they talk about family heredity. Social and developmental factors and gene expression. What that means is basically, and Alfred Adler was one of the best theorists to break away from the current trends in thinking back under Freud, where Freud felt like that it was all suppressed or repressed memory, and so Adler took it a little further and said that someone's social development and the factors and how they express, or the ability to express, or the depression, or if someone were to stifle stifle someone's abilities, then, and here's the prime example. Let's say that a child 5 years old is either physically or sexually abused. That can trigger developmental factors, and you've heard the term arrested development, that can cause that person to have dysfunctional behaviors, which may not be genetic or even may not be brain chemistry, but may be social oriented in their main reasoning. Learning and neuron function, or learning disabilities, and then counseling and therapy and gene expression. Okay, so the neurobiological theory includes genomics. Genomics means that the person is going to look through, or they're going to evaluate if there's any predisposition for any of the MAP genes that, and they're constantly, of course, the Genome Project is a very famous thing, and I mentioned this in class during our lecture, but it's a way for them to review and see which certain, with studies, if there is a hypothesis of a certain gene being linked or related to a disorder, then that would be present in all those who had those diagnosis or symptoms. Also, the diathesis stress model, which has to do with coping skills and ability to deal with stress, gender, neurotransmission, and biological rhythms. Of course, I mentioned here that Women tend to have a greater tolerance to pain, and also, in most cases, are seen as more emotional creatures, and that has a lot to do with the onset or input of certain disorders. There's separate disorders for women than there are men, but then most disorders may have higher numbers of one or the other, but can be seen in both genders, populations. Now, neurotransmission means that and this is where we talk about substance-induced psychosis or substance-induced substance dependence, where someone may use alcohol and drugs. I use the light switch example here. Maybe they never would have been predisposed to alcohol or drugs until they take the drug, and when they take the drug, a switch goes off, and that's the addiction. And when that switch goes off, then they become predisposed to the substance. And then biological rhythms. Well, women, we know that women have different hormones. There's something called dehydrogenase, which affects the way that women process alcohol, which is a lot of people say, oh, it's the size is the main reason why women handle alcohol differently, but it's not. It's an enzyme called dehydrogenase. That's something important to know. Some older theories of mental disorders were interpersonal, just that people couldn't get along, social interpersonal, or interpersonal, that they had internal conflict. Gender bias was prevalent until around the 1900s. And then a crisis-driven or crisis theory of mental disorders, that someone is unable to deal with crisis. And then there's the behavioral and cognitive. Of course, we know our intrapersonal theorist was Sigmund Freud and Erik Erikson. Sigmund Freud felt like that one's capacity for dysfunction was within themselves, and of course he had the psychosexual stages of development, as well as the id, ego, and superego. So he did a lot to help focus on how people could evaluate and then identify and work towards reducing and eliminating their symptoms, becoming asymptomatic. Harry Stack Sullivan, and then Abraham Maslow. Abraham Maslow is the most famous of the social interpersonal theorists. Maslow came up with the hierarchy of needs, and if you've taken very many classes in this program, you know what that is. That your most basic needs must be met first, which is your food and physiological, food, water. Then after that is shelter, safety. And then after that is love and belonging. And then after that is self-esteem or some type of self-fulfillment. And then if all of these are met, the pinnacle of the hierarchy of needs is self-actualization. Realizing the best that you can be, or being the best that you had hoped to see yourself to be, or reaching your goals. Now, gender bias means that gender roles can limit psychological development and inhibit intimacy. The more rigid roles of what a man can do, or what a woman can do, or what a man should do and what a woman should do, can cause someone to have arrested development. Now, a crisis theory, usually resources and coping skills are ineffective. A person may be 100% healthy during normal day-to-day life, but with the death or the loss of a loved one, or any other type of crisis, then they may have, according to Erickson, they may have irrational beliefs, or Beck, they may have irrational beliefs, which causes their perceptions to be askewed from the reality. They have inadequate coping skills and support systems, or they have to change their perception, of course, and someone said this in class this week, perception is reality, but they must go on to a point where they develop coping skills and utilize support systems, either in family or support groups, to help them if they go into a crisis mode. Of course, and if you take behavior modification, or if you've taken it or will take it, B.F. Skinner is all about operant conditioning, and that the functional analysis can be applied to any type of behavior, because we look at it as and this goes forward the next slide with CBT, and I'll backtrack a little. Behavior therapy is, antecedent behavior consequence, but you have to remember that when you're looking at the functional analysis of evaluating treatment, which we're going to talk about in a minute as well, you do a baseline. After you do the baseline, then you do a treatment phase and evaluate and apply treatment, and then you do a follow-up to see if it's successful. So behavior therapy really was what laid the basis for what we now call evidence-based practices. Researching some type of program to see if it is effective and if it is making the desired outcome. Now, Aaron Beck developed schemas, that we all have schemas. Schemas are like our values or attitudes. Our cognitive schemas is the automatic thoughts. And the cognitive triad is automatic thought leads to feelings, and feelings leads to behavior, and a behavior will always lead to a consequence, either positive or negative. Personality theory it means the personality theories tend to say that a person is responding to their environment, and personality is usually developed and intact by age 5 to 12, and then your personality will develop from there. The personality side of this theory says that there's interaction between temperament and social learning, and what that means is there's interaction between a person's ability to deal with their own emotions and not project them on others, and to categorize and look at the different parts of their self without being so, or allowing their personality to be overwhelming to themselves and others. Now, nursing research is on value and influence on outcomes, and that's what we're talking about here. What we're talking about here is evidence-based practice. Now, it's controversial. I remember my counselor, whenever I was in treatment years ago, was talking about that there was this new thing coming called evidence-based treatment, and so there's still debate about it in the field, but evidence-based treatment is definitely something that helps to show us what programs and what theories and what curriculums really work. So what are nursing psychiatric technicians? Well, they need to be critical thinkers. You have to think on the spot. You must think independently. You have humility, courage, integrity, perseverance, empathy, and fair-mindedness. Now, keep in mind that when you're working in a psychiatric technician, this is why I want y'all to wear your scrubs to the competencies, is there are practices such as wiping a client's nose, changing a client's diaper, an elderly client's diaper, and these are all things that I did in my mental health technician. Things such as working to de-escalate clients who are having delusions, and really crowd control a lot of the times, and you get to sit with the therapist and see the therapist do their work as a technician, and you oftentimes help them with their notes, and as well as being backup and support for the rest of the unit. Now, there are these 6 standards to psychiatric mental health nurse practicing. It's assessment, diagnosis, outcome identification, which would be our follow-up, planning, implementation, and then evaluation. So it's very similar to behavior modification principles. Now, in the assessment, and this is what we're going to be doing in a couple of weeks, we're going to be doing client education. You're not going to do assessment per se, but you are going to do an interview, observation, and then a client education. So you're going to do an intake with a mock client from one of the other groups, and in that intake you're going to describe to them the process of entering into the program. There's also neuropsychiatric assessment, which is where a psychiatrist or some other type of neurological doctor comes in and test for any type of impairment, and then physical assessment. So we're going to do the vital signs and stuff in a couple of weeks, and we'll talk more about those other assessments. Number 2 is the diagnosis, nursing diagnosis, and then we're going to work in this class from the DSM-IVTR still. I'm still in the process of researching and studying the DSM-5. I will be, however, giving you some of those updates as class goes on. Outcome identification, NOC. I'm going to have to look up NOC and NIC. They're in your book, but I was not able to find those. So the roles of the psychiatric nurse is socializing agent, much like a social worker, a teacher, educator, a model, modeling the appropriate behavior, advocating for clients' welfare, counselor, role player, and Malou manager. And Malou is another word for illness, or you're containing any type of illness. And if one person has a cold or sickness, you're going to do whatever you can to make sure that that doesn't affect the rest of your clients or your patients. Evaluation is where you evaluate and document client progress towards outcomes. We call this treatment planning, and you're going to apply the goals. There's formative and summative, and this is a lot like we talk about with SOAP notes. Formative, which is just direct data information, and summative, which is a summary of observations, and then self-evaluation as well. The therapeutic relation I-thou from Gestalt technique is very similar here. You must be able to relate to clients. You must be aware of any uncertainties that you may have and any concerns, and realize if it's transference or countertransference. If you have had or have a elderly grandmother in a nursing home, and you're very emotionally tied or emotionally not able to deal with that, then that would be something that could be transferred onto your clients in your care. And then also, self-care is so important in this field. If you don't take care of yourself, you cannot take care of someone else, which is why I don't answer emails on Sundays. Caring for others. Remember that you're a part of a team. When you work as a multidisciplinary team, that you have to find joy and ability to share with the other staff members you're working with, because you're going to be spending a lot of time together. And remember that you're not there for a social club, although you do want to have camaraderie, but you need to remember your primary focus is the client. And then the client-centered approach is very important. In a hospital, things are client-centered. They're collaborative. You'll have a MD, a regular doctor. You'll have a psychiatrist. You'll have a social worker. You'll have a therapist. You'll have a case manager. You'll have an LCDC. You'll have an advocate. You'll have so many people working as a part of your team there. Keep in mind that the relationship is goal specific. We're working on certain goals, and we need to document, especially when we're talking about psychiatric symptoms, we need to document the progress that's being made. And it's theory based. All of the things that you learn in theories class and the different theories we're going to look at in this class, you'll see how they're applied to psychiatric situations. And you must be open to supervision, and you must be also open to feedback. So the phases of a nurse-client relationship, and this is just the same with new clients, is there's the introductory or the beginning phase where you're getting to know the client, the working phase where you're helping them to work through their goals, and then there's termination. Now, this is also called discharge in our field. The medical field and the therapist field call it termination, and it's discharge. But when the client has met their treatment plan goals and either moves on to another level of care or ends their care in your care, their stay in your care, then that's considered termination or discharge. When you're in the introductory phase, you need to make sure that you talk about your education, be friendly, ask questions about the client's family or anything that they're willing to talk about. Talk about your roles and your purpose in this client's life. You need to go over any type of agreements or contracts. Talk about confidentiality and make sure that your release of informations are signed. Then you'll go into keep in mind, when I talk about assessment, it's a real general assessment that they do in this type of situation. Assessment will lead to diagnosis of symptoms, and then the outcomes will be the narrative or results from the assessment. In the working phase, ongoing use of nursing process, the therapeutic alliance, implementing treatment plan goals. It could be just for the client to say their name. It could be for the client to get up and walk to the smoking area or to the recreational area and stay 10 minutes in the recreation area without having any delusions or making any cuss words. You're going to implement the treatment and focus on that, and you've got 30, 40, 50 clients and you're charged with 10, but you're also going to be supervising others. It's important to look in those case files and know what the goals are, and as an interdisciplinary team, everyone will work together on that. And then I've already talked about be aware of transference and countertransference. Be aware of, you may favor, especially with a schizophrenic, if you favor their brother, their mother, or maybe someone that they didn't like, then they may transfer that on you. And then also, if you've had any issues in your past, make sure that those do not transfer over to the client. If you're having, that's why self-care is so important. If you're having those issues at home or something that is keeping you from being able to focus on the client, and it takes your distraction, then be very aware of that. Termination phase, you be very reminiscent. One of the things I just kind of get choked up thinking about it, when you work in the field and sitting here and recording this lecture. And when I spoke in class the other day, all of those clients that I worked with at the Quitman Clinic, when I was a mental health technician, all of those clients are just kind of passing through my mind. The groups that I sat in, and how kind of I felt out of place and odd the first few weeks, because these clients had all been at this facility for some time, and there were new clients coming in and some clients leaving, but the core of these clients had completed a great deal of their psychiatric PHP at this program. So I really got to know some clients there, and I didn't think that when I first got there. I thought I really didn't think that I would get to know them, but when you see through the disability, when you see through the symptoms, there are beautiful people, schizophrenics, people with major depressive disorder, people with multiple substance addictions. They in many cases, these are the ones who, medication treatments may not work, or they may work only to a certain level. But these clients, the one thing that I know for sure is that by being there for these clients, we offer them hope. So you want to go through the evaluation process, give plans for the future, and help the clients and yourself cope with the feelings for the ending of the relationship, because it is a client nurse relationship, which is almost like a client therapist relationship. There are components, and this is what we're going to close with today. There's physical, psychosocial, spiritual, and power. On the physical side, you have to understand that there's a shift for evidence-based practice. You've heard me talk about this a lot in a lot of classes. What that means is for us to identify a problem, link the problem with outcomes and intervention. In other words, if we have all these treatment goals and we're not meeting these treatment goals, we need to do something different. And we need to do something different, or pull from a pool where something for someone else has worked, and so we're going to take that and use that then. And then synthesize evidence from research, design a change, implement and evaluate, and integrate and maintain. For information technology, you have to realize the effect of HIPAA, and we're also going to talk about a new act in a couple of weeks that has a impact on the organization and delivery and education. In the future, we have, of course, I just mentioned this at the beginning of this lecture, that we have increasing world population, more people with chronic illness, just more people in general, and then we'll see an increase in role of alternative therapies. Here's some nursing resources for you here. And then, of course, the slides are already on Blackboard if you need to. NAMI is a great organization. It's the largest grassroots organization for people with mental illness. And there's Gary Eagleton is in the Houston area if you want to connect with him on LinkedIn. He is the director of the Greater East Harris County NAMI. coalition. So I look forward to seeing you in class next week. I'll be recording the ethics lecture next and then have it posted for you.